So, hello everyone, and welcome. Welcome everyone in this room, and welcome those of us who are joining remotely. My name is Deborah Jones, and I'm the chair of the board of the BC College of Social Workers, and we are here today to conduct our annual general meeting for the year ended December 31st, 2017. The AGM will be followed by a presentation addressing the opioid crisis in our province. We will have a reception following the presentation. I would like to acknowledge at this point that we are meeting on the unceded ancestral territory of the Squamish, Tsleil-Waututh, Musqueam, and Kikate Nation. So, here is our agenda, and I think it's safe to say that we do have quorum. Basically, our bylaws state that for general meetings, a quorum of 21 registrants is required, so we certainly have met quorum. Is there anyone here who would like to add anything to the agenda? Hearing none, I will take it as approved. So the minutes of last year's AGM are available through the link on this page. All right then. The following screen lists all of the board directors for 2017. As you will see, there are 8 elected social workers to the board, and there are 4 members of the public who are appointed by the Minister of Children and Family Development. And that's because the Ministry of Children and Family Development administers our act, the Social Workers Act. So having members of the public on our board is an essential component of effective oversight of the practice of social work registrants. So in terms of the 2017 directors who are in this room, we have, let me see here, do we have Emma here, Emma Goheen? Okay, we do have Chelsea Minhas. Chelsea, do you want to stand up and be recognized? We have Andrew Kerr. Do you want to stand up and be recognized? Thank you. Sandra Harker. Okay, and in terms of the public members, we don't have any of the 2017 public members here. And of course, I'm here as well. So we figured that one out, I'm sure, pretty quickly. Okay. So, report from the chair. So, basically, I mean, my role is to tell you about what we've been doing for the past year, 2017. So, all of the highlights and you know, just looking at the sort of strategic directions that we had set up in 2016 for the 2 years. So, the first thing that we had some accomplishments with is the reconciliation with Aboriginal communities. So on March 1st, 2017, the BC College of Social Workers became one of the signatories to the Declaration of Cultural Safety and Humility signed by all BC health regulators. As a follow-up to that historic signing, board directors from the college attended a fall symposium. Attended a fall symposium. The symposium, and it was featuring First Nations Health Authority. So the symposium focused on enhancing and advancing understanding of cultural safety and humility with the registrants of all the regulatory health colleges. In addition, the college sponsored a project beginning in 2015, which you know some of you are familiar with, entitled Towards Developing Respectful Relationships. And we hired Nashwedo Creek consultants to gather province-wide feedback from Indigenous elders, social workers, and communities. The final report of the Nashwedo Creek consultants was presented to the college board on March 28th, 2017. An outcome of the project is that the college formed a standing committee of the board, a standing Indigenous committee of the board, requiring at least 2/3 of the members of the committee to be to self-identify as Indigenous. So the mandate of the committee is to strengthen college relationships with communities and to advise the college on how to incorporate and implement cultural safety and humility in everything we do. So another strategic direction that we made some headway on is strengthening college capacity. So succession planning has always been an ongoing issue for the college. In consultation with government, the board has reviewed and revised ways to strengthen capacity by limiting the duration of the term of chair of the board, creating a past chair position, making the vice chair position a chair-elect position so that mentoring is built into the executive on the board. In addition, we have looked at performance appraisals for the registrar, the board chair, the individual board directors, and for the board as a whole, and they're being developed with a view to ensuring that the college is functioning well at all times. In addition, the board chair is now actively participating in interviewing and recommending director candidates to the minister. Candidates are members of the public and appointed by the minister to the college board. 2 college staff were hired in 2017, namely Darren Usher. Darren, do you want to stand and be counted? Thank you. As Director of Professional Practice, and Margaret Alala as Professional Practice Associate. Margaret couldn't be with us here today. So welcome, Darren and Margaret. Matt Scott was able to briefly step into the position of Director of Professional Practice, temporarily vacated by Selena Bateman, who's on a mat leave right now. So thank you, Matt. Okay, so next strategic direction, ensuring public safety. The college is continuing to seek removal of the exemptions to our Social Workers Act so that eventually all social workers must be registered with the college in order to use the title social worker. The exemptions currently allow, in certain prescribed circumstances, for unregistered practitioners with a social work degree, as well as practitioners from other disciplines, to call themselves social workers. Discussions with government are ongoing, as well as discussions with Indigenous communities throughout the province. In another issue that has been an issue in the past is test centers for the licensing exam. So the test centers for social work licensing exam are now available in limited numbers in major regions of the province, thus ensuring reasonable access for candidates to in the more remote areas of our province. Another strategic direction that we followed in 2017 is enhancing social work practice. So revising the standards of practice has been an important project during 2017 and necessitated consultation with many stakeholders. The college will have new and revised standards in 2018 that will more accurately reflect current social work practice, which continues to evolve over time. Stakeholder relationships. So college policy requires that all social work applicants for registration must be graduates of an accredited social work program. The college was asked by Douglas College to approve their proposed BSW program for the purpose of registering their graduates, even though the program has not been accredited by the National Accreditor for Social Work Programs in Canada. The National Accreditor is the Canadian Association for Social Work Education, or CASW as it's known. The board consulted far and wide for months with all of our stakeholders in Canada and determined that ongoing accreditation of social work programs by the National Accreditor is an essential component of ensuring applicants to the BC College of Social Workers are graduating from programs that reflect the core values and knowledge, skills, and abilities of our profession. As a gesture of good faith, the board granted Douglas College provisional approval of the BSW program on the condition that Douglas College seeks accreditation as soon as possible. The board will require updates every 6 months on the status of efforts being made by Douglas College to become accredited. So Douglas College was notified, as were all of our stakeholders, on September 16th, 2017. And then there was a reminder letter sent to them on March 16th, 2018. We haven't heard ever from them, so I'm not sure where that's at. And then strategic directions for 2018 and 2019. So the college held a strategic planning day on November 25th, 2017 to review and revise our strategic directions for 2018 and 2019. The new strategic directions are on the college website. So there you have it. And I will just speak to the strategic interventions and directions, which you can see on our poster. But basically, we're just really, fine-tuning our, thank you. We're just fine-tuning. As we knock things off the list, we're adding new things. So we're still looking at all of the strategic directions that I talked about in previous years, but we're just kind of moving along and evolving and crossing things off our list. So enhancing social work practice, enhancing public safety, stakeholder relationships, reconciliation with Indigenous communities, strengthening college capacity. So those are all really important. And actually, it was a very interesting strategic planning day that we had. And I'm hoping that at some point during our session today that you'll have a look at sort of our aspirational and inspirational newspaper headlines that we created as a group about, where we'll be in 2020. So at this point, I would like to say, I'm finished with that report, but I would like to say that we have with us a very special guest, and it's my pleasure and honor to introduce Elder Roberta Price from the Coast Salish, Snuneymuxw, and Cowichan Nations. And I'll tell you a little bit about Roberta before I bring her up here. So Roberta is Coast Salish, Snuneymuxw, and Cowichan Nations. She's the mother of 4 children and 8 grandchildren. She has worked for many years as an elder for the Richmond, Delta, and Burnaby school districts, where she facilitated cultural teaching circles in Lower Mainland schools for 32 years, and is also frequently called to support adult learners at the UBC Learning Exchange in Vancouver's downtown east side. Roberta works closely with the Aboriginal Wellness Program at Vancouver Coastal Health, where she is the elder in residence, and works with the Aboriginal Patient Navigators Program to support patients in many Vancouver coastal hospitals and healthcare centers. She also provides traditional and healing services for the Elder Visiting Program at BC Women's and Children's Hospital and at St. Paul's, which is, I met Roberta at Women's and Children's. It's been a pleasure. I'm so pleased that she's here. Roberta has worked with the UBC School of Nursing as an advisor, research partner, and elder for over 10 years, providing Indigenous leadership and support on research projects about women's intimate partner violence, mental health, and equity. She currently is a co-principal investigator on a large Canadian Institute of Health Research funded study to improve care for Indigenous people in emergency units. She is the elder for critical research in health and healthcare inequities, School of Nursing, University of British Columbia, and also sits as an elder on the National Indigenous Council on Diabetes. Roberta has accepted the position as Indigenous co-lead elder at UBC School of Family Medicine and is recognized as part-time adjunct clinical professor for UBC School of Family Medicine as of July 2017. So on that note, I welcome you, Roberta, and thank you for coming. Please come up. Yes.
Can everyone hear me without the mic? Yeah. So very, very pleased to be here, finally to get here. The directions that I get from the Google map led me right into construction and a road closed down. So when I went the other way, I couldn't turn left to turn around. So I finally got here safely. So I'm very, very honored to be here to share a welcome and a blessing for our time together today. Haichka Siem Siaya. Greetings and welcome, everyone. As Coast Salish Matriarch Elder, I wish to warmly welcome you to our traditional unceded and ancestral lands of our Coast Salish people. Mainly the Musqueam, the Squamish, and the Tsleil-Waututh, but our Stalo people came down this way strongly into our nations here in the Coast Salish territory. Very, very honored. Ceremony. Ceremony guided each and every step of each and every day of our lives, as taught to me by my elders. I have in my hand some cedar boughs, as taught to me by my elders. We would pick those cedar boughs. Each and every morning, we would go into that cold, cold water. We would be doing ceremony. We would brush every single part of our bodies off with those cedar boughs. And what we are doing is a cleansing. We are pushing all the negative and evil energy off of us so we can go about our day in a good and respectful way. As shared, I've been going into the classrooms here in the Lower Mainland for 32 years, talking about the First Nations. I am presently in 5 school districts in the Lower Mainland. I'll share the exercise with each and every one of you today that I share with those little ones right from preschool up into university, to share the meaning of negative energy and ask you to participate. Raise your hand, folks, if you've ever felt a cranky moment in your life. Feel free to raise too. That, my dear friends, is the meaning of negative energy. Can you do things really well when you are cranky? Maybe extra hard, maybe extra fast, but not really well. So brushing all that negative energy off of you so you can go about your day in a good and respectful way. Part of the power of the sacred cedar boughs when you use them in ceremony puts a protective force around you that will constantly deflect that negative energy off of you as you go about your day. Other important ceremony is taught to me by my elders is the ceremony of introduction. To share your name, your nation, your family. And if it isn't your traditional territory, always respectfully ask permission to be on that territory. I shall share that with you now. Good afternoon, everyone. My name is Roberta Price. My heritage is I am Coast Salish. I am Snuneymuxw on my dad's side, and that's where I was born. When they came to our lands, they couldn't say our names. They couldn't say our language. So perhaps when they couldn't say Snuneymuxw, they called it Nanaimo. So I was born there right on the number 1 reserve, right on the waterfront in Nanaimo. And I am Cowichan on my mom's side. The dialect of the language of my people was taught to me by my elders on this side. The language of my people is called the Halkomelem language. I knew and understood and spoke my language fluently until I was 6 years old. Beyond 6 years old, I was not allowed to have anything to do with my language, my heritage, and my culture. I was actually tortured about that. I have spent well over 40 years reclaiming back my identity, searching out for my family, and especially searching for my mother. Very, very proud and pleased to finally find my mom when I became a grandmom in 1994. I was able to spend 8 years with my mother before she passed away. My mother affirming all the teachings of all the elders that I worked with leading up to my mom. She'd say, yep, that's right. Yep, that's the way we do things. And I'd say, hey, Mom, I'd be so excited. Do you know this elder that I work with? She'd say, yeah, that's your auntie. I'd say, hey, Mom, you know this other elder I work with? She'd say, yeah, that's your uncle. So I felt very, very strongly those elders were true stepping stones to meeting my mom. And I share with you that due to those horrific experiences from age 6 onwards, for many, many years I used the contemporary Western method of healing, counseling in psychiatry and psychology. But I really felt the greatest part of my healing journey came. I call this dear lady a friend today. My dear friend Flo was my boss in the early 80s. My dear friend Flo spent her entire life in the residential school. My dear friend Flo was also a helper to the elders. She knew what I needed, She brought me to those elders. Those elders, they took me under their wing. They taught me. They guided me. They prayed for me. But mostly importantly of all, what those elders did for me is they loved me. They loved me unconditionally. Unconditionally. Because when you are ripped away from your family, age 3, 4, 5, 6, and older, what you are missing is that unconditional love you receive from your parents, your grandparents, your family, your nation, your community. That unconditional love. They gave it to me lovingly. They gave it to me openly. I hold my hands up to those elders. I say thanks in those prayers every morning and every minute. Really, really grateful to those elders. And just as elder, I see many, many things today. Those elders, they knew who I was. But I had to find out who I am. Very, very proud to share with each and every one of you today. In the year 2018, I know who I am. And I hold my hands up high to those elders. I give thanks in those prayers for them. As I share out there many, many times, I feel that Canada has lost a national treasure. And I'm not talking about money. I feel that we've lost many, many of our elders, our knowledge keepers, our language speakers, our storytellers, and by the day. I feel truly, truly blessed that I had the grace and the blessing to work with close to 30 elders in my journey, never ever dreaming that I would become in their footsteps today. I feel truly blessed and honored of that. I want to share some teachings. I want to share some teachings of our Coast Salish elders of whom I worked with many, many years. Elder Vince Stoven from the Musqueam First Nations, where the University of British Columbia stands. Elder Bob George from the Tsleil-Waututh on the North Shore. Many, many years I worked with those beautiful elders. I feel very, very blessed. I didn't know Elders Art and Elders Thelma Stoven, but I work with them today. When they can't be at something, I'm there. When I can't be, they're there. We're like brothers and sisters today. I really truly feel that Elder Vince, amongst all the other elders, are still continuing to guide my footsteps and theirs today. I'll share and honor Elder Vince's teachings. And in a couple of minutes after I share those teachings, I'll call you each out of your comfort zone to join me in those Coast Salish teachings with me. Elder Vince's teachings are whenever we come together, we would normally be in a circle. But you know, I work with another elder, Elder Fred John. He's from our Statlian people from the Lilloit Nation. Elder Fred, when I was doing a ceremony with him in 2009, and somebody said, oh, but we can't do that ceremony because that wouldn't be traditional. Elder Fred says, hey, we can modernize. We're very, very adaptable. We'll do it, he said. So we'll follow Elder Fred's teachings today, and we'll adapt, we'll modernize. I'll share Elder Vince's teachings, and then I'll call you each up. Elder Vince, his teachings are that whenever we come together, we need to share a blessing and a prayer to cover our time together, to cover our words, to cover our interactions, to cover whatever we plan, what our plans for the future are. Elder Vince's teachings are that when we come together, what we do is we join hands. When we join those hands, Elder Vince's teachings are that we put our left palm up to our person on our left. That left palm up is the Father Sky. We put our right palm down to our person on our right. That right palm down is to Mother Earth. His other teachings are that our left palm up is to the ancestors we're calling upon and calling down in the prayers to be amongst us as we work, play, interact. Our right palm down is to our children, our grandchildren, and our great-grandchildren. When we join hands in that way, we're keeping those connections Very, very strong. So I'll give you a minute or two to stand up. If you feel like just standing where you are and you want to put your hand up and hand down like Elder Roberta, you're more than welcome to. Sure, you can join me. And maybe Deborah, if you want to join us. Sure. And if you just happen to be on an end, if it's your left hand, put it up, and if it's your right hand, put it down. And I just want to share with you, oh, we're going to move into a circle, are we? Beautiful. And I really welcome you, our wonderful tech person, to come and join us in the circle, if you feel comfortable.
I will join you, yes, but I have to.
Oh, you have to? Okay, all right. No, that's fine. Thank you. Thank you for your good work. So if everyone's ready, we'll share a blessing and a prayer for our beautiful day together here. Haichka, Haichka Ocean. We call upon you, Creator, to bring your many, many blessings down upon this special event today. We ask, Creator, that you bless anyone who is away due to illness or other obligations. Bless anyone who is yet to come, help them to arrive safely. We call upon you, Creator, to bring your blessings down upon our minds, our hearts, our bodies, our spirits. So when we think our thoughts, they are good, positive, and respectful. When we speak our words, they are good, positive, and respectful. We call upon you, Creator, to bless the people who prepared the food, bless the food and drink we put in to nourish our bodies on our journeys to wellness and strength. We ask, Creator, that you bless all the shared teachings, all the shared learnings, all the shared interactions that will go on in this special event today. And we ask, Creator, that you cover us with your special warm blanket of protection. Some of us who are in our educational journey, our professional lives, our family lives, and our lives in general. And we give you many, many thanks, Creator, as we ask you to help us reach home safely to our families each and every day. And we give you many, many thanks, Creator, as we always ask you to bring all of your blessings down upon the hurting, the hungry, and the homeless. And especially the hurting, Creator. Haichka Ocean. Awesome. Thank you, everyone. Just before you sit down, I'll share one more teaching. In the Coast Salish territory, the Coast Salish Longhouse, when we want to say thank you and honor, what we do is we put our palms up in the air in front of us, so just copy Elder Roberta, and you can copy me too. We say, Haichka. Haichka. Thank you. Let's try that again, everyone. Let's put our palms up in the air and say, Haichka. Haichka. Beautiful. Sometimes I have to get people to say that 3 or 4 times. You guys are fantastic. So when comes they do a very honorable thing, we really want to give thanks and honor. Put our palms up in the air again. And we say, Haichka Ocean. Haichka Ocean. Siam means matriarch, it means leader, it means elder, it means someone who's done an honorable deed. I raise my hands up to each and every one of you for all the good works that you do out there in all of the communities. So Haichka Ocean, thank you. Haichka. Thank you.
Okay. So, moving right along here. So the registrar's report covers pretty much everything that I covered in the chair's report, and I did want to say that Chelsea Coolidge was hired as registrar of the college on January 1st, 2017. Chelsea has left the college, and the board thanks her, sincerely thanks her for her service to the college during the past 5 years. Sheila Begg is our interim registrar while we search for a new registrar. Sheila is a very skilled social worker and mediator with vast experience as a former deputy registrar of the Board of Registration for Social Workers. We're very pleased that she agreed to step in while we search for a permanent registrar. So what I'd like to do after this is As you know, I've given you the overview for what the work of the board for 2017, and now I think it would be nice for you to hear from the individual committees and the kind of work that they focused on. And so I'm going to have, wherever possible, the chairs of the 2017 committees. So for the registration committee, the chair was Elisa Gloag, who is a public member, and she wasn't able to join us today. So we have Andrew Kerr, who's willing to make that presentation regarding the registration committee. So welcome, Andrew. Thank you.
Hi, everybody. I'm Andrew. I'm the current chair of the registration committee, which is made up of a couple of elected members and a couple of public members. There's opportunities for people to volunteer to do some of this committee work. So look for those notifications that come in your emails later on in the year to participate in these committees. So the registration committee, we meet about 4 times a year, and our goal is to review policies and procedures that are related to the registration process. The registration process is managed by the staff, the wonderful BC College of Social Work staff who's here, and all of the processes and forms and everything that people need to do to get registered is all clearly laid out on the website. And then you can see the categories of registration here: registered social worker, registered clinical social worker, non-practicing, provisional, and temporary. The registrar and the staff, like I say, manage all the process, and they are the ones who will approve applications for people to write the exam, and then approve once the exam process is finished. The registrar and the staff are the ones who grant the registration. Registration can be denied under 4 circumstances, and these are if the applicant registration was suspended or canceled in British Columbia or in another jurisdiction, if there's a current investigation that could result in a person being suspended or canceled in British Columbia or a different jurisdiction, if an applicant canceled their registration to avoid an investigation that could lead to a cancellation of their registration, or if they've been convicted of an indictable offense. If an application was denied, then the registration committee is the body where a person could apply for an appeal of the decision from the registrar, and a person has 30 days to do that, and the process is all clearly laid out on the website. So then the staff would prepare the information to come forward to the registration committee. The registration committee would review the case, and we would either uphold the refusal to grant the registration, we would grant the registration, or we can grant the registration with limits. If there was another refusal, then there's the registration appeals committee that a person could apply to if they felt that they've been adversely affected by the decision of the registration committee. You can see from the numbers that we're sitting at about 4,700 registrants right now, and it's growing incrementally every year. Every year there's a few hundred more registered social workers. You can see some of the work that the registration committee has done in 2017 in the report that's available on the website. And that's it for my report. Does anybody have any questions about registration? Hi. Numbers on how many people applied? First, would one of the staff be able to help me out with that?
Do you know what? I wonder if we could handle questions at the end of the AGM, if that's okay?
Perfect.
Okay, so please ask it at the end. So thank you so much, Andrew. That was great. Okay, so the next committee report is the inquiry committee. And the chair for 2017 was Chelsea Minhas, who is here today. So Chelsea, would you like to come up and tell us a little bit about the work of your committee?
Hi everyone, I'm Chelsea. So I'm just going to give you a little bit of a brief overview of what the Inquiry Committee is and a little bit about our work. So the Inquiry Committee is established by the Social Workers Act for the purpose of receiving, investigating complaints about registrants in adherence to the duties and objects of the college to protect the public. We held 6 meetings in 2017. There are a lot more details about what I'm telling you in the report that is online, and also there's some copies over there. This year, we had 26 complaints were received, which is an increase of about 44% from 2016. We're not really ready to talk about what might be influencing that trend. It's still early. It could have, our early guess though is it could have something to do with the fact that number one, we have more registrants, and number two, we put a lot of effort in the past couple of years about public education about who we are and what we do. So people now are more aware that we do investigate complaints and the ways to do that. So we investigate complaints from other registrants, from employers, from members of the public, whoever sends it in. So in terms of the files that we did review this year, of the 26 files, one was dismissed by the registrar, so that means that there wasn't enough for us to even open an investigation. The committee members found the social worker's conduct to be satisfactory, so we took no further action in 2 of the files that were delivered, which means those files are closed. A further 5 registrants were issued a complaint resolution agreement, and what that is an agreement between the college and the registrant about ways to enhance and improve their practice. So an agreement might include things such as a certain amount of hours of supervision, course and a certain things such as report writing or ethics or confidentiality, and there's a requirement for that registrant to participate in that and report to us once completed, and that file won't be closed until those items in that agreement have been completed. So that's a little bit about what a CRA is. The remaining 18 files continue to be investigated. A lot of work from the college staff goes into investigating these, as you can imagine. So collecting collateral, collecting documents, speaking to all the people involved. It's quite a process, and we're very grateful for all the work they put into that before it comes to us. So those files are still active. Additionally, a total of 15 files remain active from our previous year, so that means that they're carried over. We're still doing the investigation, or it could mean that there's still an outstanding CRA. So 9 of those are active CRAs that we are monitoring, and 6 are being investigated. We investigate complaints from a variety of different areas of practice, as you can see up there. These things include ethical conduct, boundaries, incompetence, misconduct, issues of confidentiality, inappropriate reports, misuse of title, and items like that. And that is a brief update on what we've been up to for the past year. We're saving questions for the end?
We're saving questions for the end. Thank you. Thanks so much, Chelsea. Okay, so the next committee, I will report. Shani Cloak is the chair, was the chair for 2017, and she couldn't be with us today. But basically, the discipline committee is established by the Social Workers Act for the purpose of hearing matters that are subject to citation by the inquiry committee. So while most complaints before the inquiry committee are resolved through remedial measures, we're really focused on remediation, there are some circumstances where a disciplinary hearing is required. Typically, if the information in a complaint file indicates serious concerns about the behavior or conduct of the registrant that cannot be resolved through remedial action alone, and it's very rare, the inquiry committee will direct the registrar to issue a citation for a hearing by the discipline committee. So there were no citations issued during the 2017 year. But I will speak to just a kind of a follow through on one particular situation. The inquiry committee canceled a citation against a former registrant in 2017 that had been pending before the discipline committee since 2009. The hearing of the citation was delayed for a number of years after the former registrant was convicted in an unrelated criminal matter. The inquiry committee canceled the citation on the basis that it was no longer in the public interest to proceed with the hearing. in reaching this decision, the inquiry committee noted that the criminal conviction could be considered in any future application for registration that the former registrant might make. All right then, so Colleen Spear was a public member who was chair of the Reg Appeals Committee in 2017. And the Reg Appeals Committee is established to hear appeals from the Registration Committee in accordance with Section 15 of the Social Workers Act. So there were no requests for reviews brought to the Registration Appeals Committee in 2017. Okay, so Quality Assurance Committee. So I'm pleased to say that Emma Goheen, who was the chair in 2017 and continues to be the chair of the committee, has just appeared with her beautiful daughter. And would you like to come up and talk about the work of your committee?
Hi, everyone. I'm Emma Goheen. This is Claire, honorary member of the Quality Assurance Committee today. So the Quality Assurance Committee has two main areas of focus. One is the standards of practice, which right now is undergoing a major revision project, and the continuing professional development program. So in 2017, we conducted a registrant survey of the continuing professional development program, and are looking at that feedback. When the CPD program was established, it was always thought that after 3 years there would be a review of the program and to see what changes, if any, need to be made. And so we'll be undergoing that this year, but we did get registrant feedback last year, which we will be incorporating. And the Standards of Practice revision project has been ongoing for a number of years. Just in November, we approved to do a registrant survey of the first draft of the Standards of Practice, which has been done in consultation with registrants from all over the province, a special Standards of Practice working group. So you may remember that survey went out in February this year, and we're just looking at the results of that now. So next year in the annual report, I can tell you about that. But that will be ongoing work for the committee for this year. The other thing with the continuing professional development program that the Quality Assurance Committee looks at is any requests for waivers of the program. So last year, as you can see, there was 9 requests, and there was two full waivers and 7 partial waivers. And those claims are due to typically very unfortunate circumstances in people's lives, dealing with death of a loved one or profound illness, either personal or of someone that they are responsible for caring for. And as you can see as well, there was about 3,475 registrants who had submitted their CPD on time, so that's wonderful news. And for those that did not submit on time, the numbers reduced drastically by the end of the year. So there was, by the end of 2017, there was only 364 people who had yet to submit their CPD. So that's my report.
Okay, moving right along here. So Finance Committee. So the chair of the Finance Committee, Doris Darvasi, couldn't be with us today, so I will touch briefly on it. But suffice it to say that the college is in good shape financially. I don't know if people are aware, but our only source of income are the fees, the registrants' fees. And obviously we want to be very careful and mindful about how those fees are spent. And so we have an auditor's report, evaluation and report every year. And the auditors have, in their opinion, they say the financial statements present fairly in all material aspects the financial position of the BC College of Social Workers as of December 2017 and its financial performance and its cash flows for the year then ended in accordance with Canadian accounting standards for not-for-profit organizations. So basically, we're in good shape, and the kind of shepherding that we're trying to do as a board is going very well. So that probably concludes the financial report. I mean, I could go through line by line, but I'm not sure that that would be useful. But certainly, if there's any questions at the end, feel free to ask. That would be it. So 2017, the revenue, which is up from 2015, the total expenses, and the excess. So there you have it. So it's actually 2016. The 2017 figures, I think, are incorrect there. So we have for revenue in 2017, $1,162,114. And we have excess of revenue over expenditures for 2017 is $283,847. So kindly disregard that. And the financial statements are attached to the annual report, which is on our website, and there are copies, extra copies there too. So my apologies, and thank you, Denise, for saving me. Okay, so moving right along then. So there's nothing that I really need to say about the Indigenous Committee other than we struck the committee at our December board meeting. And at this point, we have 4 Indigenous, self-identified Indigenous members and 2 who are not. So we're really looking forward to getting the work going there as well. So in terms of our agenda, I guess that we move into the question and answer period before we actually have a little break while we set up for our presentation. So questions? Anybody have any questions about any aspect of our report from the board? Yes. So if there's a CRA, I think typically I don't know if there's a standard time frame, but typically it's within 12 months. X number of things have to happen. So I think it's designed to be. Yeah. Oh, Darren, you wanted to add something?
Well, I can help a little bit. Maybe. Yeah. So we have a sheet when the complaint comes in, and there's specific time frames that we have to we try to abide by. Each case is very unique, and so it varies, but generally it's 255 days. Yeah, there's certain aspects of the bylaws that say we have to respond in 30 days to a complaint and things like that.
Thank you, Darren.
Okay.
Any other questions? I may need to bring up the staff and all the board members too, so we'll see.
Yes, there was a question about applicants. We do have those numbers. They're not in the report, but we certainly do have them. Yeah. If you add the number of registrants and the number of people refused, you get a good idea. But it's not actually the number of applicants because there are certain people in process to be registered. So that number would be different. Yeah, you're correct.
Any other questions? Oh, yes.
I'm just wondering if there's
That's a very good question. So maybe I can just clarify. So basically, we have a regulatory function. So in other words, for people who are applying to be registered, they have to have a social work degree or in some cases a related degree. But then once they're approved for registration, and there is a process for registering, whether there's all sorts of things that are part of the registration process, which is on our website. But then they must write the licensing exam. So when we have the regulatory part of so that the college is the regulator of the social work practice, right? So we are the ones who register new candidates and superintend the practice of everybody who is registered. Then we have the professional association, and so our mandate is to protect the public and make sure that social work registrants are competent and they're held to standards of practice and a code of ethics, and we really try to ensure best practice. With the Social Work Association, that's where you would get the registration as a student. It's not a regulatory function, so you don't even have to necessarily be a social worker, I think, to be part of the Bccsw. But we do have the executive director here, so probably. Yes, Diane Heath. So probably at our break will be a good time to network when we finish the next presentation, and then we'll have refreshment time. But so there's two different functions, and even though many of the provinces in Canada appear to have jointly the two functions, they're actually separated within. So here they're obviously separated, and in a few other provinces they are as well. But even the provinces where it looks to be one body whole, the two roles are separated. So you cannot be a regulated social worker if you haven't finished school. But you can be registered with the association, which is all about promoting the profession. And so oftentimes we work very closely with the BC Association of Social Workers because, they're very great at sort of promoting learning opportunities and workshops and that sort of thing. So we work hand in hand, but we have very different functions. Does that answer your question? Well, to be regulated, we under our act, you must be registered in order to call yourself a social worker, except for certain circumstances. And the certain circumstances are, except if you work for government or an Indigenous authority. However, those exemptions are just as they were removed for health authorities and other exemptions, that is the end goal, to remove all exemptions so that you must be registered as a social worker in order to practice as a social worker. So that's our desire. But I hear you loud and clear. But really, it is they are the two different functions. And when applicants must write a licensing exam, so that's very much part of. You need to have finished school in order to be able to write a licensing exam. Yes. You can't combine the function. I mean, it used to be when I was first registered as a social worker in this province, it was under one umbrella. So we were combined like in other provinces. However, it was very separate. The roles are so. I guess so. When we paid our fees, we were actually paying our regulatory professional dues that we had to pay annually, but we were also paying our professional association. It was divided out. So there hasn't been any thought to going back to that. I think it tends to be a bit clearer when the roles are clearly delineated. Diane? Yeah, and who knows? Maybe it's easier in terms of registrants being also, when they pay their fees, it would be for registration, but also to join the association. And so, the one annual fee. Sorry, someone's gesturing to me. Would be sorry. Okay. Any other questions? Oh, okay. Okay, so an RCSW is a protected title, so you have to be an RCSW in order to call yourself a clinical social worker. So basically, in 2006, the board at that point decided that they wanted to make the clinical licensing exam optional. So a number of us wrote it that year in January of 2006. And basically, the reserved action that's implied according to our act is that registrants with an RCSW designation can diagnose under DSM-5. So that's the big distinction. So I don't know if that clarifies things. And I think the impetus for bringing our CSWs into BC was because it actually came from mental health, and certainly physicians really supported it. There was a lot of social workers who were doing preliminary assessments and preliminary diagnoses in the mental health system, but they technically didn't have the licensing requirement to do that. So they were in full support and really encouraged the college to look at making the clinical licensing exam an option. So, but again, it's not mandatory. And so the numbers are low. I mean, the numbers you saw were just who applied last year, but the reality is, I think there's probably about 120 somewhat of us. 169?
Yeah.
Thank you, Andrew. Did that answer your question? Well, we're probably going to evolve to that. So a good question, but it is a reserved action under the Social Workers Act. And the impetus really was coming from sections of government to bring it in because they wanted to ensure that social workers, our CSWs, could diagnose using DSM-5. So.
I can just add, the college is working on it, and we've just developed, the registration committee just developed guidelines for applicants because it was a little vague. So we have much clearer guidelines, and we hope that that will encourage more applicants. Receive probably 2 or 3 applications per month, and then those people have a year to sit the exam. But I think there is some work to be done with the industry to recognize that designation. Yeah.
Thank you. And the lady in front of you had a question as well. So I can answer that. I mean, not in terms of exact numbers, but the reality is, if I could just sort of dispel a myth, the licensing exam that we require in BC is entry to practice, and it's if you're graduating with a BSW, you would write the BSW exam. If you're graduating with an MSW, you'd write the MSW exam. And so basically, it's testing the skills that you should have on the first day of your first job as a social worker with those academic credentials. So I've been involved with the exam program now for, I don't know, about 12 years because I'm a writer for the exam, the clinical exam. But in any event, the stats, it's a North American-wide exam, and there are other provinces who are looking at implementing it. They were sort of waiting to see what would happen in BC first. It is mandatory in all of the states at various levels, whether it's a BSW exam or the clinical exam or whatnot. But anyway, the statistics are such that typically for the BSW and MSW exam, the master's and the bachelor's exam, we are looking at, I think, in the sort of high 70s as the general pass rate. Within BC, it's the high 90s. So we are looking really good. And it's the same exam, North America-wide. And it is for North America exam. Having been a writer for, over 10 years, I would say that I can guarantee it's an international exam, basically. And also, just kudos to BC. I've just lost my train of thought, so on that note, are there any other questions?
I believe the pass rate for the BSW exam is about 95%, and the MSW exam is about 93%. Those numbers are very high at the moment because we have so few exam participants, because we only started recently. So we're expecting, as we get more volume, for that number to go down a little bit and eventually probably line up with the North American 75 number, but we're way away from that. Yeah.
Yeah, I mean, it is impressive, I think, that BC candidates for the exam have done very well. And it really is testing. Oh, that was what I was going to say, that, compared to other licensing exams like law or medicine or pharmacology or whatnot, the stats for the social work exam are really high in the sense that it really tests the knowledge that it's supposed to, as opposed to being random. So in other words, if a candidate wrote the exam and failed, what that says is they need to study and learn more before they can expect to pass it the second time around. So it's very, it's valid, and it's, yeah, so it's a good exam compared to all of our other discipline colleagues. Apparently, we rank very highly the social work exam. So other questions? I see that we're kind of moving along here, and I want to make sure we have time for our presentation on the opioid crisis. Are there any other questions? Yes.
Yes. Yes.
So can I just briefly answer that? So being involved with the exam program for over 10 years, basically there's representatives from every conceivable, whether it's culture, ethnicity, region of North America, that sort of thing. So yes, I mean, they have to appeal to, I mean, I'm using the American, but Hispanic, African American, Native American. So I mean, that's the terminology used in the States, but the same goes for Canada. So yes, the writers represent all of those that kind of cultural diversity and ethnic, or ethnic diversity and gender, and geographic. So yes, it's a very important consideration. It's a high stakes exam, and so that is very much part of it. So just to reassure you. So one last question, and then I think we'll break. Thank you so much for that. Because being a writer for so many years, I mean, all of my colleagues represent every other sort of diverse, whatever, and it's actually a pleasure. But thank you for that. That clarifies it.
Can I just add that the exam is an algorithm that pulls together questions for each specific exam, so nobody will sit the same exam. It's pulled together, and you get a unique exam pretty much. So you wouldn't be able to say mine had no cultural content. How much did yours have? Mine had lots. It's what happens on the day through the algorithm.
But the data bank with all the items is one that reflects all of our diversity. So, okay, so on that note, unless there's something pressing, I would like to adjourn the meeting, and maybe we can take a 10-minute bathroom break while we set up for the presentation. And then following that presentation, then we'll have refreshments at the back of the room. So thank you so much, everybody, for your patience.
Hi, welcome back. So the next part here is the education portion of our meeting, but it's going to be slightly different than your normal kind of lecture or presentation or something like that. And it's talking about something that impacts us all in different and unique ways, and that's the opioid crisis and the tragedy of so many people dying from overdose, for people that we work with and people that we love. And so what we're doing here is a bit of like a reflecting circle. Unfortunately, a couple of the people who were going to participate in this were unable to attend at the very last minute. So it's just the three of us here, and I'm going to let each of us is going to introduce ourselves and what our role is and why this issue is so important to us sitting up here, and all of you have reasons why it's important for you as well. And then my friend Mark here is going to ask us some important questions, both on the stage and from you as well, because we want this to be this space here is for all of us, not just for us on the stage here. So with that, why don't Dawn, why don't you introduce yourself?
My name is Dawn. I'm a social worker, obviously, and I'm actually the team leader of the Maple Ridge Intensive Case Management team with Rain City Housing, so in partnership with Fraser Health. I worked for Fraser Health for a few years and got called back kind of to the nonprofit world, as I'm sure many of you can understand why that would happen. So yeah, so we're very much on the front lines of the opioid crisis. So I'm honored to have been invited here, and yeah, I'm looking forward to kind of sharing that. But it is something that I'm seeing with the staff I work with myself personally, every single day. So.
And I'm Andrew. I'm on the board of the college as my like nighttime pastime, and during the day I'm the team leader with Kelowna Mental Health and Substance Use, specifically with the supervised injection, the mobile supervised injection service, and the opioid agonist treatment clinic, so the methadone Suboxone clinic up there. And so, you know, me, when I was in social work school, I never pictured that I would be like responding to an overdose, administering naloxone, administering oxygen, you know, having to manage the space of being there, being the lifesaver, the literal lifesaver for somebody who's not breathing and non-responsive. And I have the power with naloxone and the tools and the training to bring somebody back, and then more importantly, to be there to have a conversation with somebody if that person is open to having a conversation at that time. You know, in this role, I was as a clinician and then moving into leadership, really seeing the stress of it, right? You know, the numbers are staggering, as we all know. The death rate continues to climb. The pressure from government, from our communities, from the different agencies, housing, health, criminal justice, all these different agencies who work with folks, there's this immense pressure and pointing and requesting for help, right? People look, when I sit at a table, they say, okay, thank goodness the health authority is here. You know, what are you doing to save people's lives? When it's so much more than that. And then I go back and I have to sit with my staff who've lost their clients, who've lost people, who've lost family members, right? That's the reality. It's not just our clients who use drugs or have mental illness. It's our brothers. It's the sons, daughters, brothers of our coworkers, of the people in our community. And so there's so many elements of grief in that. And the pressure of doing our jobs is always there, right? We have all these deaths, but we just have to keep going, right? Have to keep going. And how do we do that? And I struggle as a leader. I struggle as a leader in supporting staff. You know, sure, I can send people to their extended health benefits and hook them up with a counselor and stuff like that, but they still have to come to work every day, knowing that they could get a phone call or an announcement that somebody else has died. And so that's one of the things that I struggle with, and I won't hog your time, Mark. You got to introduce yourself too. But I'm looking forward to this.
My name is, thanks, Andrew. My name is Mark Goheen. I'm a clinical services lead in Fraser Health and in the world of mental health and substance use. And I was just going over some numbers today. So the coroner's report is always adjusting as investigations are concluded. But looking at 2017, 1,461 brothers and sisters in this province are no longer with us. And obviously the count is more than that just because of the investigations. And the fatalities are not randomly distributed. There's disproportionate realities. And one of the pieces that I think is of particular relevance in the field of social work, there are very clear social determinants to who's dying and who's overdosing. And Andrew, just to pick up on something you said here, I don't think anybody in this room, if you look back on your professional training, was ever equipped for this. In fact, this is true for even first responders. At some level, we're never equipped for this. At a very real level, we still really don't know what we're doing. We're still figuring this out. If we look at the figures from 2016 to 2017, we see over a 60% increase in fatalities. It is a runaway train. And obviously, this is a highly politicized issue, which is often getting in the way of what it is that we need to do. So there are so many different layers here, starting from which is that we need to find a certain truth to the overdose crisis, and we need to give voice to that truth in the midst of all the noise and the fear and the panic and anxiety. On top of that, we have to manage our own lives. On top of that, we have to support staff. On top of that, we need to organize and align our programs and services around this overdose crisis. So I think today is really an opportunity to acknowledge some pieces that perhaps aren't being fully acknowledged. There are some inconvenient truths that the overdose crisis has brought to our attention, and I think part of our work is to try to help us individually and collectively acknowledge those inconvenient truths, because as long as we persist in not acknowledging those truths, the dying will continue. So on that note, we were thinking about a full-fledged reflecting team, and which is really kind of some of you might be familiar, it's kind of rooted in the work of people like Michael White of Australia, and really is rooted within social work to try to help render public what's invisible. So there are certain lived experiences and knowledges and truths that lay hidden underneath sort of the dominant discourses in our society. And reflecting teams are really an opportunity to give voice to what's hidden. And I think today both of you bring some very real, vibrant, still pulsating realities about the overdose crisis. And I notice when I'm listening to media, there seems to be a fair amount of acknowledgement what's going on for first responders and the burnout. And there seems to be a fair amount of acknowledgement of some of the difficulties that families bear. But there hasn't really been much acknowledgement or discussion about, if we look at our mental health and substance use services and other social services, how this is landing at the level of organizations, at the level of leaders, and of course at the level of people who are delivering services at the point of care. So I'm just, first of all, I think one of the ideas that we were talking about earlier, and maybe if you each could maybe talk about what this has been to you, is that this isn't just about the work we're doing, this is also landing in our personal lives. I think it's very few people have been spared this. There's almost all of us have a friend or a family member who has lost their life to the overdose crisis. And then we have to show up at work and summon up the strength and sort of the centeredness, the groundedness to be present for the people we serve and also for the people that we serve alongside. So I wonder if maybe reflect on the last 2 years, what has it been like to kind of carry those two worlds of, we have our friends and family and children that we're worried about or we're grieving over, and then we've got to come to work the next day and be present in the lives of people who are suffering with overdose.
So I think what we were chatting about is it's almost like going, finishing one job and going to the next. So as social workers, we often get called upon with our families to be that support person, or our friends who might disclose their substance use or what's going on for them before they tell anyone else, or when there's grief or loss. So I know I'm exhausted, to say the least, of feeling like I told Mark, I was like, shit, like I'm sitting here and I get a text from someone who, on one hand, I'm like, awesome, he's alive, he's not dead today, that's great. On the other hand, I've got a weekend of social working with him ahead of me because he's losing his housing and all this stuff happened. And this is just a normal friend of mine that I met in, the hot tub of my condo. He's just like a normal pal. And, when you think like, yeah, so I do this Monday to Friday. Really, I don't. I do it 7 days a week for Rain City because of the on-call stuff. But and then when we look at our personal lives as well, it's how much longer do we get to sustain this? And when I look at my employees, most of them are kind of early 30s or in their 20s, and it's like how are they going to sustain themselves in doing this work when I know for them as well in their personal lives as in their professional lives, they're tired, they're exhausted, they're it's like double duty with the opioid crisis.
One of my wife's cousins died of an overdose. It was a cousin that it was a distant cousin, and my wife's family, I love them dearly, but but many of their views are very different than my own when it comes to drug use. And so I had never heard of this cousin before he died, right? And none of the family members talk about this person who died during family gatherings, other than, oh, did you know he died of a fentanyl overdose? And that's about it. And I struggle with that, and I don't share that story very often with coworkers, with the people that I work with, because I didn't have a relationship. I didn't have a relationship with that person. But lots of the tables that I sit at are with moms and brothers who, through their loss of their loved one, they've tapped into this strength to try to change the world. And so are people who are very public in going on the radio, going on TV, advocating with government, advocating with all these people. And so even though I have a similar experience in my life of someone who's in my family who died, I don't feel the same connection to that death as this wonderful woman who's using the loss of her 2 sons who died of an overdose to really change the world. I think that's a way. I don't know if that's like a protection thing for myself. I think of one of the women that I work with. We learned of one of our clients who died of an overdose, and she was totally distraught because it was a client that who had been sort of banned from lots of places. There's this handful of people in communities who kind of get restricted from service, from shelters, from social service agencies, from health offices and stuff like that, and clients who get reputations within staff, right? There's kind of like those internal discussions of, oh, so-and-so's back in, that kind of thing. And then when we learned that this person had died, one of the admin staff was totally distraught because the admin staff said that she knew that this person's story. She knew that, that this woman didn't really feel welcome going to many other places. And so this admin staff tried to go the extra mile to welcome her, to compliment her, to thank her for coming in for her methadone appointment that week. And then for her to hear that the client had died after she invested so much work into building and maintaining that relationship was extremely difficult for her. And this, we have a very busy methadone Suboxone clinic where some days we'll see over 100 people every day. So now I think, how do I support that person and all of the other admin staff who don't, the admin staff don't have the same training as lots of the clinical staff do, and oftentimes are excluded from training about, kind of dealing with all the heavy stuff that happens at work. So I'm struggling on how to support, because this isn't going to be the only time that we hear about one of our clients dying. Yeah.
So one of the things I'm wondering about there, when we look at that, so as people in leadership roles in your organization and with staff, and obviously this is landing on staff no matter what their role is in the organization, because people develop familiarity and relationships with people. What do you suppose that people need? What do staff need when there's these losses, and how are our organizations showing up for people to help them move through this? Over and above, here's the pamphlet for the EAP, right?
And I think that's something that's changed my practice as a leader. I have a master's in leadership in human services, and I've been in management for about 10 years. And this is the first time that, as part of my new staff orientation checklist, it's so when a client dies, how do you want to be notified? This is actually part of our new staff orientation, and that's kind of messed up, right? We didn't go into social work, and on your first day, you're like, okay, so when someone dies, what's your preference? And that was partly realizing that every person is an individual, and some want to know when they're on their days off because they're going to hear through it through friends that work at the agency, and they want to be able to grieve on their own time. And some are like, don't you dare call me on my day off and tell me that a client died. So we actually have that now as part of our new orientation checklist. And I just think wow, that's pretty messed up, right? It used to be if a client died, it was a pretty pretty big deal, and it still is, but it's becoming such a regular occurrence or part of our practice that that we've had to implement that. So that, yeah, that as a leader is like, wow. So, you know, welcome to the team, and can you fill out these forms? And one of them is, how do you best want to be notified, and what supports do you want in case, or in not case, but in the event of a death?
You know, Dawn, when you look back over the last 2 years, you know, for example, at Rain City, at your organization, how many people that you have served in some way have lost their life to overdose?
I can say thankfully on our ICM team, we have not had any fatal overdoses, thankfully, for Narcan, but the number of reversals that the staff have been responsible for is incredible. Agency-wide, I don't know if we take numbers, but we had our leadership meeting yesterday, the managers meeting, and each person just goes around, and it was just more like a death count. Like, so we had 2 this month, we had 3 this month from each of the programs. And one manager said, you know, I didn't really sign up to be a funeral director because, you know, we're often with people who don't have, Rain City often serves people who've been isolated from their families, communities, and so the celebration of life, or, you know, that falls on us. So, you know, someone that really hit home of like, I didn't sign up to be a funeral director. That wasn't in the job description, but that's, you know, we just had 2 this week for one of our programs, so I had to send some of my staff over because that team is, you know, a mess. They had 2 in 1 week. So my boss said like, hey, can you spare someone that can just go and just help the clients that need a hydro account set up and housing and stuff like that. So, so the implications are huge organizationally. Yeah, just the mood of those leadership meetings is pretty sad, just around how it's impacting the organization. And I find it interesting too that like first responders, we think of police, fire, and ambulance, but the real first responders are the staff working in supported housing, the outreach workers, the people who are finding people who are down and who are actually administering the Narcan and calling 911. So I don't know if there's like a term for that, like first responders or like pre-first responders, but I always find that really interesting that, you know, we get these people in uniforms and they're called the first responders and they get discounts at the baseball game and stuff. But like the real first responders are, you know, the frontline staff who often aren't even registered social workers. They're social service workers or frontline workers without any formal training. And so then that falls on, you know, leaders to sort of provide that support and training. They didn't have the opportunity to go to a bachelor or master's program. They're $22 an hour sort of frontline staff who are the real first responders in this crisis, and then it falls on us to support them.
So, and this is an important piece too. I was thinking about how many of us at all these different levels and roles have been involved in either fatalities or reversals and all the stuff that goes with it. I was just thinking about our own daughter, who just recently registered as a social worker. She was at a Rain City location in the Tri-Cities, and in the first week, she personally conducted 3 reversals. She had no training, but she just intuitively knew how to break open the vials and fill the syringes. And but you know, we're really talking about the extent to which people's lives are hanging in the balance, but we really are not equipped. And I know that there's been a lot of pushes around training, but it's still, I don't know whether I'm just misconstruing what's going on. It still seems to me we're doing a lot of flying by the seat of our pants, and people's lives are hanging in the balance. I know that, Andrew, you've been involved in a lot of reversals. What has that been like for you personally, or for your staff to be involved in reversals? I know it's a life-changing event. That's certainly one of the ways I would describe it.
It really is, and it's like even just thinking about it, I can like think of the adrenaline rush of it too. And I've probably been involved with over 20 reversals, mostly from the supervised consumption, but also a couple that happened like in the washroom at the mental health center. And it's hard because, you know, even you do them, if you do them a couple of times, you don't get desensitized to it, but you're prepared for the emotional impact of it, right? So after you have a couple of reversals, you know what it's going to feel like, you know what the adrenaline is going to feel like, you know what the effects that you might see, right? So for me personally, I try to think of like, what can I do better the next time that this happens? right? And it's checking in with myself about, was there anything about my reaction to this overdose that contributed to make it, could it have been better, could it have been worse, whatever. and then reviewing that with the team, I find that there's lots of reluctance, right? It's kind of like with other kind of first aid situations too. Everyone's always grateful when someone takes the lead of the situation, right? And then now that I'm a leader in the organization, people look to me to be the leader because that's on my business card, right? And so I'm trying to own that. I'm trying to own that in trying to do training with people so that it's realistic, right? Like it's fun. It's fine to sit around the table, do naloxone training, and do your practice injection in a little smiley face or a teddy bear or something like that. But we can do a simulation where you can replicate. You can use the person. You can do it in a bathroom. You can borrow equipment, like airway trainers and stuff like that, so that you can kind of run the whole scenario to prepare people for the actual event. Another thing I was thinking too about is about the almost unprecedented investment in substance use services from the government, like through funding new programs and new positions, which is amazing, right? Those of us who kind of worked in mental health and substance use know that substance use services doesn't always get the funding that it deserves. But now with the overdose crisis, at Kelowna Mental Health, we have over 15 positions created in the last year based on the overdose crisis. And then I reflect of the people who are in the positions. They're not people who come from the substance use field. They're people who come from hospital, from mental health, who come from lots of different areas. And I struggle with helping prepare people. I recognize everyone brings themselves and brings lots of strengths to the field, but our supervised consumption is in a 30-foot RV that's 8 feet wide, and when an overdose happens and 3 paramedics and 3 firefighters show up and there's maybe still 3 clients sitting in there, it's really difficult to prepare someone for that pretty intense situation.
This sort of desensitization that I hear of is, I know for either of you, is that something that you've personally experienced or you're witnessing in staff? Because it's a very human thing, and I know that it's been very difficult to acknowledge that because it's so antithetical to the values that social worker and other care providers have as a mission in their work. Is this something that's been creeping in?
I think in order to sustain yourself in practice, I've been a social worker for 15 years. I think there needs to be a level of desensitization. I don't know if that's healthy. I hope that it's not showing with my work with clients or with staff, but you got to be able to show up the next day. You don't get to take a mental health day the day after a death or an overdose or a reversal, because there's not enough sick days for that. But also someone's got to keep showing up for the clients that are still alive. And I think that's a really important piece of some of the work that Rain City we do with Vicki Reynolds. Some of you may know her, is around in this type of crisis is you still have to show up. You can't just peace out because a client died. So we've got to do what we need to do to show up the next day, and whether that's a desensitization or what needs to happen. But we can't just be another death, we're all going to just take some time off. We can't do that, right? Not when there's 1,400 something people dying in the province. We wouldn't have staff, right? So we have to be able to desensitize enough to keep showing up. But I would also query, is it, for me, desensitization or is it hope? Because the reversals means that people aren't dying. Every overdose reversal is when a person that isn't dying. And I worked substance use downtown Eastside and downtown Toronto before Narcan. And that was really, really hard because you are waiting for the paramedics because you don't have access to Narcan. You're initiating CPR. And I'm I don't know if my CPR practice is that great. That's not what I went to social work school for. So with the reversals, and maybe that's the desensitization, or maybe it's hope, is I can actually do something now. I actually can carry a Narcan kit, and I can start the process to bring this person back, and I can actually make a difference in that number. So yeah, so I see kind of two sides of having been a frontline worker pre-Narcan in the downtown east side and downtown Toronto doing substance use work to now where I am, I feel like I'm equipped. And I remember the anger. I was a manager at Fraser Health for like a super short period of time, like a year. And Andy, the executive director, was talking about how, social workers like us, we weren't covered in our scope of practice to carry Narcan. I was like, you're not going to tell me if I'm carrying Narcan or not. Of course I carry Narcan. and then Marika was just like, oh, he looked like he was going to slide under that table because I was like, what? You're not going to tell me it's not in my scope of practice to save a life when I've been trained to do it and carry a Narcan kit. I'd been trained outside of the organization, but that's one thing where I was like, yeah, I'm willing to lose my job to save someone's life. Like, if you actually want to, cool, call the College of Social Workers and tell them Narcan someone when it wasn't in my scope of practice because Ivy hadn't got to that just yet. But I just thought like that's just silly because it's, that little kit is something that does bring hope to our work, and maybe that's where the resiliency comes from, whether it's desensitization or hope. But that little kit is something that I don't have in my backpack right now because I gave it away, but I usually always have with me as that tool of resilience or hope.
So maybe on that note, is that what else has helped sustain people through this? Because I see many professionals, they're still viable, they're intact, they're still dedicated. So it says to me that something is helping sustain people. So based on the service that you're involved in, what is going above? So Narcan provides us the concrete, tangible way of literally saving lives, but what else has been sustaining?
For me, it's the clients themselves, right? Kind of in recognizing the person's relationship with their substance in the first place, and kind of what the role of the substance is in that person's life, and then in hearing stories about people who've had an overdose reversal or people who've used Narcan on their buddy or something like that, or seen somebody else been Narcaned, and then to kind of like come back and feel really proud that they've saved somebody's life, right? And with the supervised injection service, we've really tried to make it a super low barrier, low threshold. So lots of the people who access the service are people who don't want to go to their doctor, would never go to an emergency room, even if they had a life-threatening infection or something. They would never go there because it's not a safe place for them to go. But they come back to us every day, right? And they're willing to receive a little bit of help or support or just not being judged, right? When they come in. And so for me, that's really, I'm this witness to this, it's like vicarious resilience for me, right? In seeing the strength of the people and being there as they're talking about their experiences with other parts of the system, and then maybe in my brief little interaction, maybe I'm changing the way that they view healthcare, or I'm building a different way for them to be in a relationship with a healthcare provider than at the hospital or their doctor. Yeah.
So, it's something we, sort of the silver lining to the overdose crisis, too. There's been, it certainly forced us, not just professionals, but our society to start to acknowledge some truths that have been hidden out there for a long time, such as there's a lot of people in our society who are hurting, and part of that hurt is because of some of the social determinants. The basic human needs aren't being acknowledged, and it's also certainly brought to our attention the extent to which colonization and other traumas have contributed to the addiction problem. If anything, it's brought a greater awareness that addiction isn't just about drugs, but it's about why is it that human beings hurt so much that you're using opioids to manage that pain.
I would have, so when I was in high school, I went to a Pentecostal private Christian school for a year, and that was an incredibly traumatizing experience for me. So I'm just kind of laughing, thinking like, I can't even believe I'd be saying this like this many years later, but our team really uses a lot of spirituality as a team, and that comes from the Indigenous teachings. So going back to the teachings and going back to, the Indigenous way of healing. So we have an incredible Indigenous specialist on our team, and he's created a safety for the team to come back to the office and be like, I need a smudge today. I need, this is what I need, or I need a story. Can we just have a story? Can we just sit down and just tell a story? And that's, like, I can't even believe, like I said, but spirituality for me now is so different than what I thought was happening then. That was traumatizing, but and it's really become really healing for us. And when I first started social work school, and I was like, no, spirituality's got no place in social work. That's like super inappropriate. It's like a boundary thing. Now it naturally flows within our practice as a team. And you know, I've got to give a lot of credit to our Indigenous specialists, but also the team who are able to speak up and say, this is what I need, knowing that this is what can be offered. So we have our smudge bowl and our sage and everything right in the office. And our Indigenous specialist has just opened that up for the team to say, like, when you need this healing energy, just ask, and it's there. So that's been, and we have a lot of clients asking as well. So when they've attended an overdose or had a death, because although we haven't had our clients die, we've had people die in the apartments. We've had their friends die. We're experiencing death. So it's quite powerful. And for anyone that's kind of like me, that was, oh, spirituality, that's not cool. I don't know. I think go back to the teachings and, look at a way of incorporating that, because that's brought a lot of resilience to our practice. So.
What I'm thinking about is like as much as I love and am passionate about the work that I do, is I don't think about the people who don't come to service, right? Like that's one of the stats is kind of like that the middle-aged man who would never identify as like their substance use being problematic, right? Someone where there might be a lot of risk in disclosing their substance use, right? Risk to losing their job, losing relationships, losing their kids, losing relationships. And that's a group of people that is dying the most right now, right? Those men who are kind of in a place, higher functioning, would maybe never come to a mental health or substance use center, would never go to a counselor. And it's, as much hope as I have for the good work that we do, there's also like this loss that I feel for a huge group of people that I'm never going to be able to connect with.
And I'd say that's where it hits me personally. So when I go to these meetings and I see this awesome stuff that we're doing for sort of street-involved folks or people who are accessing social services, I always try and be like, so what are we doing for those middle-aged guys? Because those are my friends. I've had friends die of overdoses, and I have friends at risk of dying of overdoses who will never step foot into one of these services, who I can give a Narcan kit, but we know they can't Narcan themselves when they go down, and they're using alone. And so I would say for me, that's the hard part is I represent the organization, I represent my team on different committees, and we're talking like, oh, good, we've done these reversals, we've got Narcan flooding the streets. But yeah, what about these middle-aged like white guys who are in their 30s to 40s? They're the ones that are dying, and I'm always saying like, how can we better reach this population? Because that for me personally is the hard part, because Monday to Friday I'm doing everything I can with street-involved folks, but outside of that, what are we doing for the regular folks that are our neighbors and our friends and our family members and stuff? Not to create a divide between our clients and our neighbors, family, and friends, but the ones that are hidden.
I mean, that's in some ways, this has been one of the most difficult pieces. In fact, I spent most of my day crafting together some recommendations for leadership, because there's one of the things we're not looking at, and I think it's a very sensitive issue, that if looking at the coroner's report last year, and 82% of the fatalities were men, and not once in the coroner's report was that ever acknowledged, and nor any kind of strategies. And so part of what the overdose crisis is presenting to us, there's something going on in the lives of men where men are in conditions of isolation in their hurt. They're not reaching out to their brothers and their sisters. They're not reaching out to us, and are quite literally dying alone. And so part of what the overdose crisis is teaching us is that the sort of the emotional and social isolation that men are living as, it's a bit of a blunt term, as action figures, is not helping them move through the overdose crisis. So it's forcing us to rethink or reimagine how it is that we can connect with people who are in some sense invisible. And we don't have any easy solutions, but I know that most of the deaths we are witnessing are men who are alone and in a private residence. the media certainly has paid attention to people who are described as street involved or homeless and stuff. And the good news is, and I think that's where a lot of the hope is, that the overdoses continue to happen in people who are street involved and homeless, but the responses have been outstanding, such as the reversals and stuff. But it's such an inane thing to say, but naloxone doesn't work unless there's someone there to administer it. And so most of the day, one of the causing features of the death is isolation. And again, that's very much a social issue.
Deborah, you put your hand up there. Maybe come on up to the microphone.
And so, I mean, I come to Vancouver regularly, but what has really hit me recently is all of these posters that are addressing just what you're talking about. So it's, a sort of 40-year-old man who says coworker, neighbor, addict, friend. And it's very, I found it incredibly powerful. So it's on all the Sky trains and buses, and so it feels like there's some attempt to reach those invisible people who are invisible with their difficulties, because I found it very powerful and very positive. So thank you for raising that.
Yeah, that's a fairly new development, and for me it's a bit of an emotional issue because I've lost a lot of male friends. In fact, I just found out that my best man at my wedding just died from an overdose, and so I'm seeing the statistics in my own life. And I lost a cousin a little while back, construction worker, 34 years old. And it's only recently, but it's almost taken us to the point that we've had to witness several thousand deaths before we've finally acknowledged that there's something going out there about male identities that we need to reconcile. So I really appreciate what you're saying, and I am thankful that the provincial government, the election might have had something to do with that, bit of a political comment, seems to be a lot more responsive to the reality of what's going on out there. Would it make sense to open the floor up to questions or something?
So we'll try to. I'll try to run around with a mic just so that we can all.
Andrew Donahue.
I'm in the Donahue show now.
Thank you. Just emotionally, I'm finding myself really moved listening to you all speak. And I wonder if there's something to be learned from folks who were providers on the front line in the 80s and early 90s during the AIDS crisis, and that there might be some parallels about how to cope and how to support each other. There's one thing that comes to my mind. I think there's a whole generation of folks who have a collective trauma from that. And then Narcan is a wonderful tool, and I'm really glad that that's available. I don't hear people talking at all about another psychiatric medicine that is being used off-label more in the U.S. than in Canada so far, but ketamine. It's a really powerful antidepressant, and people have been using it for folks who haven't responded to other depression treatments. But I've had the privilege to facilitate an international conference of mental health providers who are using ketamine for psychiatry, not just for depression, but also to help folks get off of opiates. Ketamine is also a pain reliever. And there's a woman who works in Haiti with really poor people. She did the Peace Corps there. She's a physician in Texas. And they can make ketamine into creams that, like, if you have sore parts in your body, you can rub it on there. And that the other researchers at Columbia have found it helps people get off cocaine, even cannabis, if they want to stop. Like, somehow there's something that switches in the brain, and the connections of neurons that it facilitates are actually getting people to use lower amounts of opiates. And I just don't hear anyone talking about that here in Canada, and I'm wondering if anyone knows anything about that or who I should talk to. I know a lot about it, but I'm not a doctor. I'm a social worker. Again, it's not in my scope of practice, but I care, and I want to make this available to more people.
I was going to say that there is some published research about the use of ketamine in response, and that's an important area. I think the problem is, and this is true about the overdose crisis in general, we're out of breath and we're barely catching up. It was just a few weeks ago that nurse practitioners are now, under their scope, allowed to prescribe opioid agonists such as Suboxone. And so we're so far away from the use of ketamine. It's only recently, and I don't know if you heard this, that physicians are now allowed to prescribe injectable opioids. That just happened now. So it was just a couple of years ago that your GP couldn't prescribe Suboxone. So now there's been some really major changes, and Suboxone and ketamine. There's lots of pharmaceuticals that are making their difference. But here's the rub: the people who are doing the dying don't talk about their addiction, and they don't go to their doctor. They're the same people that don't floss their teeth, so to speak. It's the same challenge that dental hygienists have. Is that how do you help people who somehow seem removed or isolated from their own well-being and their own health care? And I think that's part of the male challenges. And I don't want to get too far off topic here, but I've interviewed a fair number of people, both in groups and also individually, men who've experienced overdose by injecting opioids. And one of the areas I'm really interested in is sort of the phenomenology of when you're injecting, what's going on. And every single man, they agreed wholeheartedly to two things. One, they were well aware that may be the last thing they ever do. And second, there was absolutely no fear whatsoever. So this is a bit of the paradox here: is how do you encourage people to become concerned about their health when at some level they're not concerned about living? And I think that's where we start unpackaging the deeper issues of mental health and stuff, where depression, and there's so many other underlying factors to it. So this is a very complex piece, and I think our healthcare system is trying to find simplistic answers where this is so much about how people see their own value as human beings, right? I think, obviously this goes back to asking questions about how do we help ensure little boys realize that they don't have to be performance figures, that they are inherently lovable just as human beings, and can be vulnerable and can be emotional and allow themselves to be accessed by other people. I think we have to look very fundamentally about the kind of society we live in and how we make sure that men are comfortable making sure that their hearts are open to the people around them.
Hi, thank you for the sharing. Actually, I just came to Canada last year. I was quite shocked when I see the news about the opiate issue is like so big in here, and I feel very sad when the time I hear you guys. It seems that like all the burden was being taken by the frontline worker, because for me, I came here. I'm not sure if I have a correct view, but I think that here the government was not doing a lot like for the prevention. It seems that a lot of the work seems to be like how to tackle. Now there is a problem, so we try to do something to save people's life. But I feel that it seems that in the other side on the prevention, it seems that it is not doing a lot. I would like to hear the comment from you guys, because I'm not so sure if I get a correct view.
So hearing your comment makes me think of some of the research about like adverse childhood experiences and lots of research about epigenetics and all that kind of stuff. And knowing how early experiences kind of can create a trajectory for some people. And then if you haven't heard of it, you have to look up the Alberta Family Wellness Institute, where them with Harvard University Center for the Developing Mind, I think it is, where they're starting to take some of this research and put it into prevention programs, where it's largely in the U.S. and then some in some provinces, but using this growing body of research to do some of these prevention activities.
And I also jumped right to the ACEs piece, and then was thinking about all the wonderful schooling I got at that Christian school about like calculus and physics and all this stuff, but no one taught me like how about the cycle of violence and domestic violence. And as a woman, my my vulnerabilities to sexual assault, and that wasn't covered in the curriculum, but those triangles and all that shit was. So if we look at from a prevention standpoint, and we look at what's happening as far as trauma as a determinant of the overdose crisis, what are we doing on a prevention side with young people, and looking at that piece? So that I went also to the ACEs study, and if we have research that shows adverse childhood experiences are a determinant, of many, many bad things. What are we doing to prevent that from happening in young children?
Yeah, I hear a lot about the prevention is happening. The challenge is that a lot of what happens in prevention is not necessarily strongly associated with what's driving fatalities. And it's an extraordinarily complex piece. So we know from a prevention point of view is that, first of all, effective alcohol and drug prevention has nothing to do with alcohol and drugs. It has to do with, I mean, just to boil it down, and the research, the jury's been in for a long time, and I think this is good news for people in social work. The true primary factors that determine who's going to be vulnerable to addiction and ultimately fatalities is really two things. One, the extent to which people have meaningful connections in their life. That's an absolute necessity, and it's true whether you're a dog or a human being, that we need each other. That was really emphasized today in our opening, right? We're all one, right? The other piece, though, and this I think is particularly salient in a lot of men's identities, is opportunities to contribute, to really feel, I mean, to put it bluntly, it feels as if somehow you're a player in this world, that you're contributing, that you're involved. And there are many people in our society struggling to find ways to meaningfully participate, to meaningfully contribute. And I think brings us back to some of the ideas when we stand back and acknowledge healthy indigenous culture. I believe those are the two hallmarks of indigenous culture, is belonging and opportunities to be part of something. And without getting into a bit of a political spiel here, I think we need to acknowledge that in many ways the overdose crisis that we're seeing is a symptom of industrialization. And that's a very difficult and complex thing for us to wrestle with. The good news seems to be is that schools are recognizing the importance of going way beyond providing quality education or providing a safe learning environment. We literally need to think about schools as ecologies of inclusion. And as our schools get better and better at recognizing the fundamental function of schools is to create ecologies of inclusion, we will see the benefits, and we are. There's been extensive research showing that young people who feel this inclusion because of the schools and their families and communities are infinitely less likely to develop an addiction, infinitely less likely to develop an overdose. So this is a really tricky process, and a lot of the work is trying to help our society recognize that alcohol and drug prevention has very little to do with alcohol and drugs.
Oh, thank you so much, Mark, for that insight. And thank you to all three of you for this great presentation. It's really enlightening. A couple questions that came up for me as you were talking is around one, in terms of prevention, or even support for male, adult male, 40, that age group that we're not able to actually engage as much as we should be. So I'm thinking in terms of support, has anything been done around sort of, I guess, supporting employers or those people who may come in contact with the overdose? Is there some kind of process that's in place right now to help with, no matter who the employer is? Any education around delivering education for employers to support your staff? And the other question I have too is around, we talk about the deaths, the number of deaths, 1,400 close to 1,500 in the province. Do we have any statistics to support the number of rehearsals that we've had so far?
Just the number of reversals are tricky because a lot of reversals take place by people who don't necessarily like to report things. So, but we estimate, and this figure, I find it hard to believe, but it's true. I mean, at least I believe it's true because I've seen some of the data. In this province last year, it's somewhere between 20 to 30,000 reversals took place in the entire province. It's absolutely staggering the extent. Just that there's forms to be filled out, unfortunately, to track this. So there's been some statistical, but anyhow, it's incredible the number of reversals. That's the good news about this. And one of the challenges, just on that note too, is that many of the people who have been reversed, it's not their first rodeo, is that we're seeing multiple reversals. And this is another piece, and of course, where social workers have such an important role. So what happens after reversal? So we know that how we show up or how we talk or how we engage with people during and after an overdose is absolutely critical in terms of that person being motivated, so to speak, to take the next steps of getting better. A disturbing number of people will experience an overdose and within 24 hours have overdosed again. So the other piece that we need to be looking at in our organizations and our services, that if someone overdoses, to really see that as a sacred opportunity to develop a partnership with that person to help them get on a journey of wellness. We have to be very cautious of making sure that, and this is where trauma-informed practice comes in, by the way, how we show up and how we talk and how we engage with people has never been more important. Just to answer very quickly is that both at the provincial and certainly at the Fraser Health level, there's been some really good initiatives with WorkSafe BC and try to engage employers, especially in the trades, where there's a disproportionate number of fatalities taking place.
I know that there's lots more questions, but I want to be aware of the time. So I'd like to propose that we continue the conversation, but by grabbing food and maybe having smaller conversations at the same time with that. So Mark and Dawn and I and everyone else is available. The food is set out at the back, and thank you very much for your time.
And just to add what Andrew said, thank you so much, the three of you. It's been very enlightening, and thank you so much. And we do have a little token of our appreciation. Andrew, Dawn, thank you, and Mark, thank you so much. Good. So let the food begin. The refreshments. Yeah. Thank you, everyone.